We are Group 4. Our cancer is chronic myelogenous leukemia, and our targeted therapy is asciminib hydrochloride or name brand Scemblix. I'll be going over some of the basic cancer research. So first I'll go over the biology of chronic myelogenous leukemia, and then the molecular consequences of a frequently mutated tumor suppressor gene seen in this type of leukemia. So first I want to break down what chronic myelogenous leukemia means. So chronic means it's a slow progressing type of cancer, relative to other types. This also means that the white blood cells only partly mature, which causes them to not perform their function as well, which can lead to decreased immune system function, increased cell survival, like other cancer cells do, but also buildup and crowding normal bone marrow cells. Myelogenous means it originates in the bone marrow. This term can also be interchangeable with myeloid, so chronic myeloid leukemia. It means the same thing. It also means it starts in early myeloid cells rather than lymphoid cells. So in the bone marrow, you have these stem cells that are either going to become myeloid progenitor cells or lymphoid. So chronic myeloid leukemia cells, they go down this myeloid progenitor path, more specifically down the myoblast lineage, which form the monocytes, basophils, eosinophils, and neutrophils, instead of these T lymphocytes and B lymphocyte cells. That would be chronic lymphoid leukemia. So again, chronic myelogenous leukemia is a type of cancer that starts in the myeloid line of cells in the bone marrow. So bone marrow is the spongy tissue inside of the bones where hematopoiesis occurs. Hematopoiesis just means the formation of blood cells. This includes red and white blood cells and your platelets. So CML causes increased white blood cells or leukocytes in the blood. So in normal blood, you could see there's a lot more red blood cells than white blood cells. That's how it should be. But also the red blood cells and platelets aren't affected by this type of cancer. It's just these white blood cells that over proliferate and end up overcrowding the bloodstream. And it's more specifically, like I mentioned in the last slide, it's these monocytes or eosinophils or basophils, those types of white blood cells, rather than these lymphocytes. So what type of tumor is CML? It's a myeloproliferative neoplasm, meaning it's not a solid tumor like most cancers. Instead, it's a liquid tumor, and it's also known as a hematologic malignancy. So in addition to increased proliferation, leukemia cells also don't die off when they're supposed to. This is normal amongst cancer. So this causes them to build up in the bone marrow, and then eventually they'll spill out into the bloodstream when they become too overcrowded. Once they're in the bloodstream, these cells can then travel to other organs where they can inhibit normal functions, hence the term hematologic malignancy. So in addition to typical chronic myelogenous leukemia, which is usually defined by this BCR-ABL fusion gene, there are other biologic variants that are recognized. But first, in normal CML, they have this Philadelphia chromosome, which is the translocation of chromosome 9 and 22 that causes this fusion of BCR-ABL. So in some patients, they still have this Philadelphia chromosome and this translocation of 9 and 22, but in addition to that, they also have other complex rearrangements on multiple chromosomes other than just 9 and 22. Another important one is atypical CML, which is actually negative for this BCR-ABL fusion gene, and it's classified separately as an MDS or MPN overlap disorder. And ACML shows dysplastic features and it carries mutations in genes such as SETBP1, ASXL1, or ETNK1, and it generally behaves a lot more aggressive than typical CML, and it usually has a poor prognosis as well. A frequently mutated tumor suppressor gene in advanced chronic myelogenous leukemia is the TP53 gene. So P53 normally acts as the guardian of the genome that can do many things like trigger cell cycle arrest, cause senescence or apoptosis, and this is usually in response to DNA damage and oncogenic stress. So a mutation or loss of this P53 gene during the accelerated phase or blast crisis disrupts these pathways, leading to reduced apoptosis, unchecked proliferation, and marked genome instability. So if it's not able to induce apoptosis or cell cycle arrest as often, that's going to lead to your increased proliferation or longer cell survival when they should have died off by then. So this promotes transformation from chronic phase CML into an acute leukemia like blast crisis and contributes to therapy resistance as well. So there's a few familiar components that we've heard about. So the P53 protein acts as a transcription factor that upregulates key genes like P21. This enforces cell cycle arrest, or pro-apoptotic genes like BAX, PUMA, and NOXA, which help eliminate damaged or abnormal cells. P53 also interacts with major DNA repair pathways, allowing cells to correct genomic damage before dividing. Its activity is normally regulated by MDM2, which is a protein that controls P53 stability and prevents excessive activation.
Cancer process hallmark targeted by asciminib. Asciminib targets cancer cells with a Philadelphia chromosome, which is a mixture of chromosome 22 and chromosome 9. This creates the BCR ABL1 fusion gene and its oncogenic hybrid protein product. In normal cells, the ABL1 protein kinase activity is tightly regulated and only activates when needed. In the BCR ABL1 fusion, this regulation is lost and a kinase is always active. The BCR ABL1 fusion kinase sends constant growth signals, allowing leukemia cells to proliferate without regulation. So what is a proto-oncogene that asciminib targets? ABL1 is that proto-oncogene. So proto-oncogenes are genes that directly influence cell growth, cell division, and cell survivability. Specifically, ABL1, this gene codes for a protein that functions as an enzyme that changes the activity of other proteins by adding a phosphate group. This gene is responsible for activating signaling cascades such as RAS, MAPK, PI3K, AKT, and AKSTAT, as well as many other ones. So we know that the Philadelphia gene is a mixture of two different genes, which is ABL1 and BCR. BCR and ABL1 in their normal state, they don't interact whatsoever. They have completely different functions. They are in different chromosomes, and they really don't have any reason to be interacting. But we know that ABL1 is a proto-oncogene because it regulates cell survivability and cell division, but BCR is not considered a proto-oncogene. Like I said before, proto-oncogenes regulate cell division, cell growth, and cell survivability. BCR does not code for proteins that regulate these growth or survival factors. Instead, it codes for other functions, such as cell signaling, but overall, it is not fully understood. So if BCR mutates, it does not activate major cancer-causing pathways. So why are these mutations dangerous? Like I said before, ABL1 activates RAS, MAPK, PI3K, AKT, and AKSTAT pathways, which are signaling cascades that activate the production of survival factors. But once the Philadelphia gene, which is BCR-ABL1, when they fuse together, once this gene is created, these signals cause uncontrolled cell proliferation, increased metabolism, and resistance to apoptosis, allowing leukemia cells to survive and multiply abnormally, which then leads to cancer and tumors.
Okay, so I'm going to be talking a little bit about the public health problem of chronic myeloid leukemia. It's a pretty uncommon leukemia with pretty low death rates in high-income countries, mainly because of effective targeted therapies, but it still remains pretty important when it comes to lifetime cancer burdens. The data that I'm going to be going over is focusing on data from the United States. And then, so as you can see the graph, it's going to go by the rate of new cases and deaths per 100,000, and the rate of new cases of chronic myeloid leukemia is 2.0 per 100,000 men and women per year, and the death rate was about 0.3 per 100,000 men and women per year. And then all of these rates are age adjusted, and then they're based on studies that were done in 2018 to 2022 for the new cases, and then the death cases were studied from 2019 to 2023. And then the lifetime risk of developing cancer was approximately 0.2% of men and women will be diagnosed with chronic myeloid leukemia at some point during their lifetime. Again, based on data from 2018 to 2021 data, but it excluded 2020 due to COVID. And then prevalence of this cancer in 2022, there was an estimated around 75,000 people living in with chronic myeloid leukemia in the United States. And then in 2025, it is estimated that there will be about 9,560 new cases of chronic myeloid leukemia, and an estimated 1,290 people will die from this disease. So, who is getting chronic myeloid leukemia? It will vary by persons, which two of the main factors are sex and age. There's a slight male predominance, meaning there's more cases in men than in women. If you look at this top graph over here, you can see that there is an all races category at the top where there is a 2.6 per 100,000 persons compared to a 1.5 per 100,000 persons in females that will get chronic myeloid leukemia. And one of the other main factors is age. Chronic myeloid leukemia is mostly frequently diagnosed among people aged 65 through 74, with a mean age diagnosis of around 66, which you can see in the bottom graph down here. And so it's basically just meaning that the incidence increases with age, and there is about 2% of cases of people that are younger than 20 that can get this, but it's not very likely. And as you can see, the graph kind of shows as you get older, the incidence increases. And so with that, death rates from the chronic myeloid leukemia are also higher among older adults, those ages around 75 to 84 years of age. Along with this, people with leukemia have many treatment options, and treatment for leukemia can often control disease and its symptoms. And for CML specifically, the death rate was about 0.3 per 100,000 men and women. And yeah. Alright, now getting into known and suspected risk factors for getting chronic myeloid leukemia. One thing that I mentioned on the slide before is that getting older is definitely a risk factor. So the risk goes up as you get older. And while it can happen at any age, the average age of people when they are diagnosed with chronic myeloid leukemia is around 66 years of age, and about 7 out of 10 people with it are 55 and older. And again, as I mentioned, being male is another slight risk factor, just because there is a slightly larger showing that males are more likely to get the leukemia. And there wasn't an exact reason for this, and it's still not very clear as to why. And then another risk factor that's pretty big is radiation exposure to high doses of radiation. An example of this is kind of being like a survivor of an atomic bomb or like a nuclear reactor accident, which can increase your risk of getting chronic myeloid leukemia. And two of the ones that I wanted to point out that have been studied is ionized radiation, which kind of correlates more to the nuclear reactions, and then benzene exposure. The risk factors of leukemia with ionized radiation, there's a pretty strong increase in leukemia when exposed to high ionized radiation, and the risk kind of depends on the dose, the timing. There's more evidence from high exposures than there are from low doses of exposures to the radiation. And then for benzene exposure, you can see that there is like an elevated risk for leukemia overall, but overall there is not a super strong or consistent correlation with CML. And some other risk factors that there are, no super other clear ones besides those three that I mentioned. It was pointed out that it doesn't seem to be affected by smoking or diet or other exposures to chemicals or infections, and it is also not correlated with having any like family history of chronic myeloid leukemia, so that also doesn't link you with an increased risk. And then I just wanted to point out this graph or table or picture that I included here to kind of show that like over here where it has ionized radiation, we're looking at the x-rays and gamma rays that is associated with the radiation exposure that will cause certain types of leukemia.
Efficacy and side effects of asciminib. Looking at a interventional study, a phase 1 interventional study, I was able to get some details regarding how people took in this medication and responded. So its efficacy, 61.3% of them actually showed improvement with this medication. 61.6% reached a major molecular response, which was like a second stage, even better improvement. And 33.7% reached deep molecular response, which indicated that their disease wouldn't like progress anymore, or it just had halted. After about 4 years of treatment, almost 70% of patients were still taking the drug, showing good long-term tolerability. So overall, the efficacy of this medication was very good. Although there were some side effects. There was high pancreatic enzymes, low platelets, and high blood pressure, as well as low neutrophils. These were considered like the more severe type of side effects. Now going into the more common, it was muscle or bone pain, upper respiratory infection, and fatigue.
Hi, I first want to start off by talking about the clinical use and the prognosis of asciminib hydrochloride. Asciminib hydrochloride is a drug that is usually administered to a specific clinical subgroup or a few. This would include adults, and I will be specifically looking at adults. I wasn't really able to find a lot on pediatric use, so just adults with the Philadelphia chromosome positive chronic myeloid leukemia in the chronic phase. This would be considered a primary subgroup for treatment through asciminib hydrochloride, and it would usually be administered after resistance to the standard tyrosine kinase inhibitors, and especially in those who have already had at least 2 tyrosine kinase inhibitors. Asciminib is also used in chronic myeloid leukemia patients who carry the specific T31-5I mutation within the BCR-ABL fusion, blocking the ability for other drugs to inhibit the ATP binding site. And specifically looking on one specific subgroup who should not be taking this drug, it was shown that it has been shown that women who are pregnant should not go on this drug because it has been shown that it can cause a lot of fetal harm, and it should definitely, before being administered this drug, a woman should be checked to make sure that she isn't pregnant. Now focusing on the prognosis aspect, untreated leukemia has shown that people usually have around 2 to 3 years of survival, but that is solely if you don't get any treatment at all after being diagnosed. And however, it is shown that if people go on asciminib hydrochloride, that there tends to be a very drastic positive change in their direction when considering survival rates. Asciminib is able to work and provide a strong molecular response that improves survival rates, quality of life, and decreases the overall progression of leukemia. This drug is most likely administered to patients who have already received 2 or more tyrosine kinase inhibitors, like I have said previously, that have either been affected by mutations or by other factors. Now focusing on propensity for spread, in chronic myeloid leukemia, it is usually diagnosed in the chronic phase, and this accounts for 10% of the blood and bone marrow being affected by the disease, and in this case, leukemia. And since this disease is considered to be a blood disease, staging the progression or metastasis can be tricky since there isn't technically a physical tumor to monitor the growth from. Instead, it is measured through progression within the blood and bone marrow, counting the cells that are still being affected by leukemia. Without a targeted therapy, especially within cases with the T31-5I mutation, the disease tends to show a lot more aggressiveness. Chronic myeloid leukemia is also able to advance from a chronic phase to an accelerated and then to a blast phase. And what this is showing is that from each of these steps, it shows that progression shows a large increase in how severe the disease is. However, while being administered, asciminib is most likely able to decrease the disease progression. The drug is able to work and reduce the signals coming from the BCR-ABL and tend to drive the leukemia growth. And another thing I also want to point out is that this drug would be considered a cytostatic drug since it is working to slow or stop progression of the disease cells. And now just wanting to touch base on the treatment of asciminib hydrochloride. This drug is going to be a pill that a patient takes orally, through which it then works to bind to the myristoyl pocket of the BCR-ABL instead of the active site or the ATP binding site. Since this is considered a cytostatic drug, to ensure that this disease does not progress, it is highly recommended that this is taken continuously or until doctor says otherwise. In terms of monitoring the progression of this disease, there are several ways of doing so, and it is usually a combination of all of these things. And patients will definitely need regular blood work done, and it is necessary for the completion of blood counts every 2 weeks for the first 3 months, then monthly, along with lipase and amylase monitoring to watch for pancreatic toxicity, which could be one of the side effects of this drug. There are only a few side effects of this drug, and this could possibly be one of them, but that is a very severe side effect. Now focusing more specifically on the patient treatment and patient overall experience, asciminib hydrochloride is mostly taken at 80 milligrams orally through a pill, and this dosage should be taken once a day without food, where the patient should avoid food 2 hours prior and 1 hour after taking asciminib hydrochloride. However, looking at the highest dosage of 200 milligrams, this would be taken twice a day without food at 12-hour intervals, and it is generally recommended that the patient takes these at the same time throughout the day, so each day, same time. Asciminib is considered to be a well-tolerated drug by many patients, and they tend to show or experience very mild side effects. These side effects could include fatigue, nausea, and joint or muscle aches. And looking at the more serious side effects, this drug could cause hypersensitivity reactions such as rash, edema, or bronchospasm. And along with this, there is also the possibility of hypertension, which ultimately may require antihypertensive treatment when the patient is going through therapy. And of course, if the side effects are too severe, then it may also be necessary for the patient to stop taking asciminib or have reductions if possible. Because this drug is a very highly targeted drug to the myristoyl pocket, there aren't a lot of off-target side effects that have been recorded. It has been known to only affect a few proteins, and this includes the 5-lipoxygenase, VMAT2, and the 5-HT2B receptor. However, these don't tend to show a lot of issues for the patient. Asciminib can also be taken in a combination with other drugs instead of just by itself for best overall results. In KCL22 cells, asciminib showed a synergistic interaction with imatinib or dasatinib, which are 2 other drugs, and at high levels of inhibition, which means that the drugs are able to work better together than separately. What these combinations do is reduce the overall cell burden of the disease, and because asciminib targets the myristoyl pocket, the other drugs are able to then target the ATP binding site, which thus shows that they don't interfere with one another. And combination therapy is also used to provide a lower necessary drug dose for patients and reduce mutation-based resistance since the targets are complementary. Now focusing on the resistance that can be shown towards asciminib hydrochloride, there is a possibility of resistance in 2 major ways. First, focusing on how leukemia cells upregulate the ABCG2 efflux pump and thus actively removes the asciminib from the cells and makes the intracellular levels undetectable. And this works to prevent the drug from even working. And secondly, looking at resistance that can occur through the BCR-ABL mutations, either through the myristoyl pocket or relative other sites close to that. this works to block the asciminib from binding altogether and allow kinase activity to return to how it was before. There is no considered timeline yet for when the resistance occurs for this drug. However, it is known to obviously develop over time, so most likely months or years as this disease adapts. And now focusing specifically on which type of molecule is being targeted with this drug. The drug asciminib hydrochloride is going to be considered a very highly specific drug to a single binding site known as the myristoyl pocket. And through binding, it prevents the activation of the Abl kinase of this fusion, and then prevents downstream signaling for disease progression. It also has a wide therapeutic index because, as it was shown in several studies, the minimum dosage range could be 40 milligrams to 200 milligrams without causing toxicity to the patient. So, the wider therapeutic index, the better it is. So I would say that's pretty wide, and it shows a pretty good therapeutic index for this drug.